Welcome everybody to Osteopathy 101 podcast. We will talk about osteopathy and science. Today we are here with Dr. Oliver Thompson. Hello, Oliver.
Hello, hi, Alberto.
And hi. And in this episode, we will talk about evolution of osteopathy, and we will explore how the concept of somatic dysfunction has changed and why probably it may need to change even more. Oliver, first of all, thank you for joining us. But before we dive in, I would love for listeners to hear a bit about your story. So, can you tell us what's your story and how did you end up working in research and in education within osteopathy?
Sure, okay, yeah. I won't. It's a long story, but I won't give you the long version. I'll give you the medium version. So I qualified as an osteopath in London, in the UK. I think back in 2006, so a long time ago now. And I originally came from a kind of sports background. I'd done a previous degree in, I think, sports healthcare was the degree, but it didn't really lead to any clinical qualification. It was kind of more theoretical. And so I looked at all the different options: physiotherapy, medicine, chiropractic, and for a range of reasons, I decided on osteopathy. And I think at the time, I know why I did, but I was wrong. At the time, I think I was under the impression that osteopathy was it was in primary care, meaning that you could in the UK at least you can make diagnoses. You don't need a referral from a GP, a family doctor, and that there was something particularly interesting about osteopathy, that they had some unique kind of set of techniques maybe, or some set of theory, or some kind of distinctive approach to patient care. So that's kind of what I thought at the time. And because I came from a sporty background, I was interested in the biomechanics. I liked all the anatomy, all that stuff. And then studied osteopathy, and was still kind of into it. I had a few questions, and there was a few kind of red flags during my training, and pursued more into sports again. I don't know why, but more into sports rehab. I did a master's in rehab, so still quite kind of sporty and sports medicine-y. And then at the end of my master's, I was kind of, I think by my master's, I'd learned about evidence-based practice and this way of looking at knowledge and practice and being a lot more critical than I had been in my undergraduate osteopathy training. And I think when I was exposed to evidence-based practice and I had my first publication from my master's, I became far more critical. I had lots of questions. I had lots of questions about my own practice. I had lots of questions about my profession. I was just looking in this kind of sea of practitioners and thinking, what on earth are you doing? This doesn't make any sense. This is all wrong. Where's the evidence? And I think that kind of frustration probably brought me into research. So I started doing some teaching. I taught technique, and I taught, biomechanics, and I taught clinical reasoning. And then I did some clinic tutoring, and then just kind of went up the kind of academic ladder, supervised some undergraduate research, and then did my own PhD. And now I currently work in a university which offers physiotherapy, osteopathy, chiropractic, health sciences. So it's called Health Sciences University, and I lead the PhD program there, the doctoral program, which is quite a way away from where I started in education, but I'm glad that it's taken that journey.
If you had the chance to choose again.
No, I probably wouldn't, to be honest with you. I wouldn't choose osteopathy again. I think there are many people who are very happy doing osteopathy, and it's a perfectly fine career. I think for me personally, some of the frustrations that I experience just make it. There are probably better options for me. I don't quite know what they would be. I think, would it be medicine? Would it be not healthcare at all? Should I have gone and become a gardener or something? I don't know.
Yeah. Maybe that frustration leads you to your path.
Yeah. So osteopathy presents lots of frustrations, but sometimes as a researcher, those frustrations are energy, right? You're frustrated, you're passionate, you want to solve this puzzle. So in a weird way, the frustration drives me to do some of the work that I do. With that said, maybe I'd be better off doing something far more, less frustrating. Exactly. Yeah. Yeah. So who's to say that if I did something completely different, I might be not as fulfilled. So, but no, I mean, I still practice. So I see patients. I have a clinic in London, and I work there kind of a couple of half days, maybe 1.5 days a week, and I enjoy seeing patients. And I think my my approach to my patients isn't osteopathic. It doesn't that doesn't I really have kind of removed myself from a kind of osteopathic identity. So I don't. I'm called an osteopath, but I really don't identify with that term. But yeah, I'll use a bit of manual therapy and exercise and advice, all the kind of similar stuff that we all use.
Okay, thank you for this introduction. And let's go on with the other questions. Over the years, you contributed several influential papers that have encouraged critical reflection within the profession. Could you summarize what drives your work and your main areas of interest?
Sure, yeah, that's a good question. I think if we start at my PhD, so my PhD was looking at how osteopaths clinically reason, how they make decisions with patients, and I think that came from a position as a student when I was in the clinic, the student clinic, and you will know this yourself. You go to 5 different tutors and they give you 5 different answers, or you'd look at how different people practice and there was such variation. And I think that I wanted to understand that, and so my PhD came from that question, that observation. Everything's so different, none of it makes any sense. Why is that person doing that, and why is that person doing that? And so the normal heterogeneity that we see in practice, the differences we see, I wanted to understand why that was so. And that sparked my PhD. And I think as I looked more closely into what osteopaths do, what they say, how they think, the sorts of knowledge that osteopaths seem to find helpful to inform decisions, I felt that some of that knowledge, some of those assumptions weren't necessarily true, or they were fallacious in some way. Hence, that's where some of the critical papers came about. Well, actually, there was a short period, maybe 2023, I think, when there was a series of. I must have woken up in a bad mood, and wrote a series of 3 papers with colleagues, and being very critical of the profession. But maybe that was just a bit of a phase I was going through. But yeah, so I think just the wanting to understand the profession and not being able to understand it through the current knowledge that we had. So me reading A.T. Still or Little John, that didn't really help me understand what the profession was about.
Are you still doing research on osteopathy, on osteopathic field?
Yeah, so I can. Yeah, so I still research osteopathy. My current project, the research that I'm doing now, which is interesting to me. But my PhD, which was in 2012 or 2013, I finished my PhD, and very briefly, I interviewed osteopaths in the UK. I observed them practice. I video recorded them when they were practicing to try and understand, to create a theory about why they do what they do. Fast forward, I don't know, 10 years almost, that grounded theory was the methodology. We've turned it into a questionnaire, a survey tool, to try and understand on a much bigger population level how osteopaths practice, and that's called the OsteoTAC, so the Osteopaths Therapeutic Approaches Questionnaire, TAQ. Long story short, we've conducted that. So we developed this tool using kind of best practice and survey design, and that now has been conducted in Australia. We've profiled the French profession, so I think we had 1,700 French osteopaths complete the survey, and that's been published. And now we're currently, as of Monday, we've launched the survey in the UK to try and understand how the UK profession looks, and we plan to move it across into Italy and elsewhere. So my work, I guess, in terms of osteopathy, is still trying to understand the profession beyond just cranial, visceral, structural. That doesn't really tell us anything about what osteopaths are actually doing, how they're behaving.
Yeah, that's really interesting, and this this answer leads us to the next question, that will be: in your recent publications, you have discussed the evolution of osteopathy and argued that the field may need a paradigm shift. So why you think such a change is necessary, and what aspects of osteopathy need to be re-examined? So in simple words, what's wrong with osteopathy, Oliver?
What's wrong? Okay. Fortunately, I would direct readers to the papers that I wrote, which can highlight some of the issues, which I think are really difficult. And I think I will say that the frustrations that I experience in osteopathy, I have no doubt that if I was in physiotherapy, I'd have similar frustrations, or in chiropractic or other professions. So these problems aren't necessarily unique to osteopathy. I think some seem to be more apparent in osteopathy than other professions. But I'm an osteopath, and so my role is to comment on my profession, not physiotherapy or chiropractic. So, I mean, I think I don't quite know where to start. I suppose the challenge for me is that so much of osteopathic knowledge is traditional knowledge. It was generated many years ago, and at a time and a place which is quite different to where we find ourselves now. And the sorts of questions and the challenges facing society and people, and our understanding of illness and disease and health and patience has just moved on. But yet much of the frameworks that we have in osteopathy were generated 100 years ago. So I think one of the key issues is just do we have the tools, the frameworks to understand and help patients in a way which they deserve to be helped. So I think shortly, or what's the word? In short, I guess it's updating knowledge. So I think that the lack of contemporary knowledge in osteopathy is a problem. Clearly, that's changing, and there's people doing good work. I think there's a reluctance in some parts of the profession, because that traditional knowledge, and maybe somatic dysfunction is one example, is tied to identity. It's tied to a sense of being, a sense of difference compared to another profession. And I think that's the problem, which I can't quite figure out. How can osteopathy remain distinctive if that's something that it wants to do? I think it's something that it wants to do. I think osteopathy seems to define itself in different terms than physiotherapy or other professions, but at the same time incorporate knowledge from outside. It seems like it's a tension there. How can you both be different but the same? And that's challenging. And we can talk about manual therapy and the lack of specificity. Doesn't seem to matter what you do or how you do it or who does it or in what direction or on which tissue. And so it's very hard. And that some of that stuff applies to physiotherapy too. But yeah, maybe I'll pause there, and you might have any follow-up questions, because I can go in lots of directions.
Yeah, I would say that the other question would be probably obvious, but do you think that this limitation, this traditional knowledge, still influence education and clinical practice in general today?
Yeah, it's a good question. I think there will be examples where it doesn't, and there'll be examples across Europe, maybe even the UK, and I think in the US too, where that traditional knowledge is still very much embedded in education. And even in countries where there's regulation and a true professionalization of osteopathy, you can just look at some of the course content, and you're just like, why is that in there? And I've been on validating panels for degrees in the UK and elsewhere, and it sneaks in, it gets in there still. And even if it's not explicit in the curriculum, there's the hidden curriculum. So there's practitioners or tutors, which also conveys some of this historic knowledge. And it's not, some of this stuff might be quite good. I mean, some of the stuff, the ways that osteopaths or AT Still was talking about patients was maybe a good thing. some of it isn't. I mean, some of it just there are better ways to think about patients or healthcare. And when that stuff remains in purely by virtue that the fact it's osteopathic or it's historic or it's precious, that's a problem.
Yeah, that's very interesting. So now let's move on. Let's focus on, you cited somatic dysfunction. And so I would like to ask you a question about somatic dysfunction. So if somatic dysfunction has always been one of the key ideas in osteopathy, can you first of all explain us what in simple terms somatic dysfunction is and how, yeah,
Yeah,
historically
yeah, I
developed?
definitely can't. I mean, I have an understanding. I can't recite you. I mean, I can't recite the kind of AOA definition of SD. At least my understanding is it's in short, it's a therapeutic target for an osteopath. That it's something which they can perceive. They can either determine through whichever way, examination, palpation, I guess even case history, talking to the patients. But palpation seems to be crucial. The sense of touch and the changes to the qualities of the tissues or the perceived qualities of the tissues by the osteopath seems to be a requirement. Like it's not sufficient to just say you've got a somatic dysfunction. The osteopath has to determine that there's a somatic dysfunction, right? And the patient may not know that there's a somatic dysfunction. Like clearly, if they've got back pain, then that's, I guess, back pain is a somatic dysfunction. But according to SD, is that you can have somatic dysfunctions without any symptoms or any kind of knowledge that you've got these gremlins in your body, and these and somatic dysfunction is obviously, my understanding, is a change to some of the biomechanics. There's tissue texture changes. There's changes in fluid dynamics. There's some perceptual change in the kind of the tensions and the qualities of the tissues. And that for osteopaths, for some osteopaths, that seems to be really important. That there's a clinical significance there. That if you can, so that's the first thing, that these things can be identified by osteopaths, and that not only can they be identified, but they're meaningful. They carry some meaning in terms of whether or not that person's going to be unwell, or to have pain, or to recover. And I guess the third claim is something around that these somatic dysfunctions can be treated, that there's some specific intervention, some technique that can ameliorate or reduce or eliminate, whatever you want to call it, this somatic dysfunction. And so and I'm sure that there'll be people out there saying, no, you've misunderstood it, and it's not this and it's that. I think that's generally how it's conceived. And the challenge is that the evidence hasn't supported any of those different claims, really. That the presence of somatic dysfunction, it's elusive. We can't see it. We can't find it. And there's reasons for that, because there's reasons for that. And we also know that the idea that you can just treat somatic dysfunction through manual therapy and that equals good outcomes, again, points to the specificity, and we don't have the evidence doesn't indicate that we're that specific in terms of our intervention. So yeah, and what do you think? Does that sound about right?
It's very interesting, in my opinion, and that's why we decided to interview you, and that's why we decided to interview Giacomo Consorti as well of the team of the variability model applied on somatic dysfunction, that are the team led by Andrea Vergna.
Yeah, I'm aware. I'm aware of the kind of the group, I think in Italy especially, who are using kind of theory from either phenomenology or
They are trying to shift the point of
yeah,
view, trying to nest, I
and
would say, a more
yeah, and I think, and
cognitive
sorry to
approach.
interrupt, and I think and I've read some of that stuff. I think there's two things to say. One is I find that stuff quite hard to not to understand that, and I'm not being critical of the writing, but it's not obvious to me how that all works. The second thing is that it's still, I think you can put a veil of this kind of phenomenology or theory around it. It still relies on the osteopath to poke around the person's body and to say something about that person's body. to say this is stiff or it's sore or there's some change. You can't use that. I think it is used to create some kind of framework to understand somatic dysfunction, but the original flaws, it doesn't really get you out of the problem. Well, we can't find these. The reliability around palpation is dreadful, and so I don't really know the kind of utility of it.
Yeah, they try to dodge this
A little
obstacle
bit, yeah.
using this inactive approach, in the sense I can't say that a somatic dysfunction is a somatic dysfunction till my patient tell me, confirm my sensation. So this is
Yeah,
the
exactly.
interesting passage.
And
Anyway,
the question is, well, when is this? When is a somatic dysfunction not a somatic dysfunction? I mean, if the theory goes that it's kind of vague and it's ambiguous and it's everywhere and it's around perception, well, then it becomes, you're kind of moving. It's like it's a moving target. We say, right? You can't really. Well, what is it? I mean, uh, lung lung cancer, and I know I'm being unfair because lung cancer is a well-defined diagnostic category, and somatic dysfunction, this is the challenge. Either somatic dysfunction is a very specific thing, or it isn't. Now or it's inactive and it's embodied and it's something else. So you can't really have it both ways. You can't say, well, this is a true kind of biomechanical, biological phenomena, but actually it's all about subjective experience. And well, which one is it?
yeah, that's interesting. I can't answer you. The thing is, yeah, the thing is probably you can call it with another name, not somatic dysfunction, but you can call it. I'm referring to the neurostatic and active process. You can call it process and not somatic dysfunction. Sorry for being redundant, but it should be studied. I'm not from one or the other side. First of all, it will be super interesting that people as well, osteopaths as well, can have access to this discussion, because as far as I know, not all osteopaths knows about this discussion.
Yeah, and I think what I'm not clear about is and I, what I it, is it helpful? I mean, does it having this kind of a framework or phenomena of somatic dysfunctions? We've got the kind of the diagnosis and we've got the treatment of SD and the examination, which kind of is how to identify it, if you like. Is this the best way to go about? Even if it is, let's say it might be untrue, it's not true. So let's say we all agree that actually the evidence for its existence is terrible, but it might be metaphorically helpful. Like it might pragmatically, it might be, or actually, even though we know that it doesn't exist, and it's not specific, it's just a helpful way to kind of communicate with patients or begin to bring in aspects such as touch or whatever it might be. And I just wonder, is it even that helpful? I mean, it might not even be very helpful. Like, given that it's so laden with biomechanics and anatomy, and the fact that it's called dysfunction, and when patients think of it, they're probably thinking of very specific parts of their body, and we know that's not very helpful. So it's both kind of, I think, untrue, but also not very helpful, even if it was untrue.
Tell me if I'm wrong. So there is, if you are treating a somatic dysfunction, you are treating a spot on the body. So that spot could be the leader of pain of a person.
Yeah, exactly. And I think for some patients, they'll be fine. They won't that, but for others, that might be, they begin to kind of internalize it and think about it, and it changes their perception of their body. And the question is, and I'm not naive enough to say, oh, you're going to cause everyone to have chronic pain. They're going to catastrophize. I realize that many patients don't care, but there'll be some patients that will find that approach quite unhelpful, or it will perpetuate unhelpful ideas, and it will kind of it'll encourage the ideas around, well, there's a part of my body which is different or damaged or dysfunctional, and my osteopath can identify that, and I've got to have treatment for that area. And so I just wonder whether it's the best way to talk to the best story that we can tell ourselves about how we help patients.
Yeah, that's interesting. That is the same problem that or issue that I think any professional, healthcare professional face off when they deal with pain in general. Probably in, for example, CFT as well. No, what do you think about that?
Yeah, but CFT is a good example where it's not perfect. Don't get me wrong, but it seems to make more sense. And it seems to make more sense both on an evidential level that these different components of CFT and the kind of real kind of biopsychosocial aspect of CFT, it seems to make sense in terms of the evidence. And when you tell patients a story which is kind of framed around CFT, around behaviors and thoughts and anxieties, that to me seems telling them you can either frame the discussion. Sorry, you can either tell a story about their problem using somatic dysfunction to guide that conversation, or you can go with CFT. Now, CFT seems to be more helpful because it gives patients control, empowerment. It avoids some of the traps that somatic dysfunction is guilty of. So it just seems like, well, why would I use? If I had a choice, I'll just use CFT as an example. I'm not saying that it's the best ever, but there are other options out there. And in the paper, the What's Wrong with Osteopathy paper, we make that case that there are other theories to better understand patients than some of the current osteopathic ones.
Thank you very much for your for this talking. And the thing is, another interesting argument could be, do you think that you can compare somatic dysfunction with cognitive function, CFT? For those who doesn't know what CFT is, we are talking about cognitive functional therapy. Maybe we can do another episode on that one, on that therapy. And do you think that is more comparable? Because, there is a lot of etymological or lexical differences, if we want to be precise. But do you think that we can compare CFT to somatic dysfunction, or it would be better to compare CFT to osteopathy in general, or probably no, because of CFT is part of physical therapy? I don't know. What do you think about that?
Yeah, it's a good question. I'm just gonna, I'm gonna think out loud, and I haven't thought about it, but it's a good question. And as I say this, I don't presume that it's right. I could be wrong, but I'm just thinking how I might approach a patient in my clinic. And let's say back pain is a common example, and they come in, and they have some of the signs. They're rigid, they're stiff, they're sore, and if I put my kind of somatic dysfunction hat on, I will be interested in parts of the body. I'll be interested in what they tell me about those certain parts. I'll want to feel very specific landmarks or segments. I'll have some interest about the specific segmental motion. Maybe I will be interested in the kind of the corporeal, the kind of structure, the posture. And yes, I might say, but I'm interested in the whole person. But for that moment, I'm interested in L4 or L5 or whatever it is, the elbow. Versus CFT, which you'd also be interested in things like body tension, stiffness, how people talk about that. You'd be interested in how they move, but in a slightly different sense. You'd be looking at behaviors and strategies and safety behaviors and vigilance. But you'd also be interested in things, in bracing, in tensions. I mean, you'd still be interested in the muscles and bones and joints, but it just has a different story around it. And so I think you can. I think if you had an identical twin and we trained you up in CFT and your identical twin in somatic dysfunction, and you could somehow create two separate realities, and they saw patients there were, somatic dysfunction, treated them using the SD model, and you saw them using CFT, I think you could compare. You could notice how the practitioner approaches the person, the relationship they have with that patient. Is it with their body or is it with the person? Are you truly interested in the kind of psychology, the sociology around that person? Is that at the forefront? Or actually, are you interested in, the spine and the tissues, and the sociology and the psychology is kind of there, but not at the forefront? So I think they are comparable.
Yeah, that's super interesting. Do you think that this is a little off topic. Do you think that there is, I would say, a communicational function in the sense of touch?
Yeah, I think so. I think so. So I touch my patients all the time, and you know, you can I definitely think there's value in touching people's bodies, right? And touching people's muscles and having a sense of people's joints and there's a few and that's all the osteopathic stuff, right? All the kind of behaviors that if you saw me do some of the stuff in my practice, you would think, oh, that's an osteopath. But there's a few things which will be different. One is that as I'm doing that, I'm not communicating anything around pathoanatomy or specificity. So I'm doing it because I think it is helpful to know whether something is sore, right? It's helpful to know levels of tension and guarding. They're all helpful things. But what I'm not doing, I'm not communicating that to patients. But what I am doing, by me going through that process, it does a couple of things. One is that it shows patients that I really care, that I'm taking their problem seriously. That I'm not just saying, you've got back pain, take some ibuprofen. I'm not even going to examine you. So I think the fact that I'm really interested in that part of their body, that creates sense of trust. It builds a therapeutic alliance, which we know is predictive in terms of outcome. So it really demonstrates expertise. So the patients will think, oh, this guy really knows what he's doing. And like, he knows where he's pushing and he knows what he's doing. He's an expert and I trust that I will get better with him. So that kind of charade or that ritual, which Rossettini would say, that kind of therapeutic ritual will be really helpful. At the same time, you can explore sensations with patients. So you can push and you can stretch, and patients will say, oh yeah, that feels different, or that feels sore, or that's my pain. And you might have a conversation about, okay, well, what do you think about that? What are your thoughts? And you start to get a sense of some of their underlying beliefs, which might be helpful to understand why they're in pain. So I think that I think all the kind of technical skills that osteopaths have, that can be really helpful. But it's the stories that go around the technical skills which are the problem, right? It's the mechanisms or the perceived mechanisms, and and I guess what we say to patients, and that's a real problem, or can be.
Yeah, yeah. You think that there's a problem because leads. I think that the idea is that this kind of approach lead to the idea of the patient have something to fix or to adjust. So if we go through that idea, it's I would say nocebo.
Exactly, yeah, and again, I think we don't want to overplay that. Many patients are resilient. They're not going to be bothered if you tell them that their whatever L5 is rotated to the left. But there'll be some patients that will be really bothered by it, and if we're not able to discern how resilient is this person, how should I communicate with them? But there is a bottom line truth that if you're saying something which is untrue, which is not proven or not established by evidence, I think there's an ethical issue there. So as much as we can be truthful. With that said, maybe there are some white lies that we can tell. When I say white lies, small untruths which aren't harmful but actually have some bigger benefit later on, perhaps. I'm not sure.
And this leads to the other question that I would like to tell you, that for the patient that expect a structural explanation, how can we deal with them, maybe speaking, but without losing credibility or trust? Or
Yeah, really hard, really hard, and I don't pretend that I get this right. I get this wrong quite often, and I think trying to find out the sort of explanation that they want. That's the first thing. So some patients don't care what explanation some just want anything. They're not so fixated on a particular idea. And through conversations with patients, you'll already get an idea of where they are. Their positioning. Are they quite biomedical? Are they much more kind of psychosocial? What are their own underlying beliefs? As they're talking through their problem, as they're describing their back pain or describing the causes of their back pain or the things, they'll give you clues about how they're making sense of their problem. And I think if you can try and, in those initial moments, try and get a sense of the sort of understandings that they already have, then you can tailor your explanation in a way which makes sense to them. Now, if patients are pushing you for, if they want a structural explanation, then I think you can talk about things in regards to structure. You can say you've got sensitivity around, if someone comes in with back pain, you're perfectly fine to speak about the back. I mean, you can say, yeah, I mean, you've got some sensitivity around maybe the joints, maybe the muscles, it's sore. If they're pushing you for more, yes, but is it because of my posture, or is it because of some other kind of biomechanical structural reason? You might say, well, yeah, we can talk about posture, and we know that when you're in pain, posture can make things much more uncomfortable. Or when you've got back pain, it can often feel like you're out of alignment, like you've got tensions around various parts of the body. So for sure, you can feel like you're out of alignment, but actually having a look at you move really well, actually. So I think you can kind of validate some of their concerns, but at the same time speak honestly, and also speak helpfully to them too. So I think having an argument with the patient and say, no, I'm not going to tell you, I can't say that, or there's no evidence for that, I think then you start to kind of rupture that relationship. Exactly. Yeah. And so sometimes, like I was saying about some of the white lies, maybe some things you just let them think that, and you don't address it at that moment, and maybe later on, maybe then you say, oh, I remember we were speaking about posture, and are you happy to, for me to share some thoughts? So, so I think it depends on where that patient is at that moment.
I heard from one of your podcasts you said, say less, simply say less. If you are not,
Yeah, there's a great, and that's not me. That was there's a great quote, and I forget it now, from Peter O'Sullivan actually, who came up with, and it goes something like, I don't know, even if you think it, just don't say it. So yeah, so even as a clinician, we have really, horrible structural ideas about patients. It's one thing thinking it, and it's one thing that those thoughts or those beliefs informing your behavior, your practice. It's another thing saying that to patients. So even if you think it, just don't say it, right? And that's, I think, so just knowing, yeah, I think that's a really good way to kind of think about it. Is just be really wary about what you say. And I know myself, I know when I've been a patient, when whether it's a doctor or you listen to every word that they're saying, like every word's important, and you go home and you think, oh, they said this and they said that. So we've got to be very careful about how we describe, how we communicate with our patients.
and I would say independently from somatic dysfunction, yes or no. So that's very interesting and helpful. And to wrap up, what key message would you like would you like clinicians and students to take from your work in general, or for what you said so far?
Yeah. Wow. I think. What can I say? I think I can just acknowledge that it can be really challenging to be an osteopath, and I'm pretty sure that most osteopaths are really well-meaning clinicians that want to do good, right? And I think probably, so when you, given the kind of the discourse and the evidence, it can feel, as a new graduate or even as an experienced graduate, it can feel, you feel a lot of uncertainty about what you're doing, and how to help patients, and how should I think about myself as an osteopath. There's no difference, and physio and all that stuff that goes around. I think despite all of that, you can still deliver good care to patients, and I think the idea that good care has to be osteopathic care, or you have to embody the principles of, AT still, or you have to draw upon somatic dysfunction, I would take a far more kind of agnostic approach and just draw upon any evidence as long as it's within your scope of practice, which best serves the person, the patient. So don't feel any professional or historic debt or obligation to 80 Still. 80 Still does not care whether or not you used his, third principle, or no one cares. Like it. So this weird that we have this historic obligation to preserve these ideas. That's both not true, but it's equally untrue if these ideas aren't helpful. We should just, yes, we acknowledge that they were part of the profession at a certain time, but yeah. So that's my. I don't know what my lasting comment was. Just to be confident that actually you don't feel anxious that you're not treating like an osteopath, or you're not behaving like an osteopath. Just deliver effective care based on the best evidence and your willingness to help that person.
Yeah, that's super interesting, because this sensation of frustration, feeling of frustration, is really actual, I would say, is really nowadays. Yeah. And finally, last question. How do you see osteopathy evolving over the next 10 to 20 years?
That's a good one. I think it's going to depend. I think it's true. That osteopathy is facing challenges globally, and I was just on a research residential fellowship in Bali, which sounds very nice, and it was very nice. But we had. I'm part of a research group called SOLAR, which is it's now called CORAL, which is the Center of Osteopathic Research and Leadership. And there's maybe 15 or 16 researchers in osteopathy from Canada, France, the UK, Australia, New Zealand, Brazil. And we meet once a year, and we come up with research and projects, and we talk about stuff. And what I do know is that it's going through a tricky time, both in terms of the programs, which are many, at least some in the UK, have closed down. The educational programs have closed down. I know in other parts of the world that recruitment is down, so students are choosing not to study osteopathy for different reasons. And so the profession has some challenges, and I don't know how it's going to get over them. I think we have to. I don't know. I mean, I think where I see it, I'm really not quite sure. I think it will probably be around for a bit longer, but I think it does. And I think, even though the touch side of things for osteopathy isn't necessarily my deep interest, I can see that the way that the world is going with LLMs and AI and this kind of depersonalization of medicine, of healthcare, that actually having osteopaths or individual practitioners who talk and who touch and really have that kind of humanistic approach is and will be valued. And so I think in a way, I think weirdly that all the stuff, all the criticisms around manual therapy, it might turn out that that's the thing that that preserves the profession, whereas accountants and economists and all these other professions will be gone because of AI, and osteopathy will still be hanging around, which is interesting. And if that's the case, that's fantastic, because I've got to put the emphasize that people will say, that Dr. Thompson, he doesn't even understand osteopathy. He's not a real osteopath, and he hates manual therapy, and both of those things are untrue. That I understand. I've got a pretty good idea about what osteopathy is about now. I've been doing it, enough and read enough about it. But osteopathy has value. I think it has value to patients, and we just got to find a sensible way to deliver the care that we do. So I hope it's around for a bit longer. Yeah.
Yeah, thank you very much for your answer. It has been such an amazing journey to talk with you, so thank you very much for everything. And I would say that all the citated literature of this episode, I will share it with the listeners. And thank you very much again. I think that we will stop the recording, and maybe see you in another episode. I don't know.
Yeah. It's a nice way to spend my what is it, Thursday lunchtime. So I'm happy to.
Thank you very much.
Thank you, Alberto. Yeah, really nice to speak.